My name is Diamond Fernandez. I'm your founder and director of the HeartFit Clinic. As you know, we are in Calgary, Edmonton, and Vancouver, and soon to find our way out east as well here in the in the near future, we'll say. And we're very excited to bringing innovative ways. And as a clinic, one of our philosophies here is to make sure that we could be super nimble and be able to adjust as the research shows and be able to be very progressive and innovative in helping people prevent and reverse heart disease. So this is why we decided to bring on this heart scan that is really a revolutionary way of finding out where your risk is of heart disease, looking for ischemia, looking at conditions of the heart where we were never able to do before. And so we have this new technology at our fingertips to track disease progress and be as accurate as cardiovascular testing. So I have Dr. Sam Fillingane on the call with us today. So welcome, Dr. Sam.
Thank you. It's nice to be here.
Excellent. And Dr. Sam, he did his medical training in Kansas City, and he calls himself a cardiovascular risk reduction specialist. And so as a medical doctor, he now practices back in his hometown in Mississippi. And we're very fortunate, I'm very fortunate to have met Dr. Sam and understand his insights on how to really prevent and reverse cardiovascular disease. As you know, I'm a student of this all the time, and the moment that you decide you're not to is the moment you decide that you're going to be a dinosaur. And we'll talk a lot about that today with Dr. Sam. So thank you very much, Dr. Sam. I'll let you kind of introduce yourself, and we'll get started through that process of it.
Very good. Well, it's nice to be here. My practice has been devoted toward the risk reduction of cardiovascular disease. And back in the day when it was unheard of to see plaque reversal, nearly 30 years ago, we were reversing plaque in my office. And it was exciting because at that point, we didn't realize it could be done until it could be done. And then we perfected the technique. And that's what I've been doing for the better part of the last 25 years, is taking high-risk cases from all over the country and taking medically and reversing their plaque, not reversing with stents, but medically doing it. Now, I will tell you, this heart scan that you have gotten at your clinics there are going to be the biggest game changer that I have seen in my 30 years of dealing with this cardiovascular risk reduction. It is going to basically allow us to do things we've never been able to do before, because we're going to be able to see things that we've never been able to see. And the accuracy of this machine is unbelievable. You probably have been watching the news late, and there's been a lot of talk about artificial intelligence. Well, this device has been 23 years in development, and it's an electrocardiogram centered around the ability to use artificial intelligence and a lot of incredibly fancy math to see things that we couldn't see before, because it takes the EKG and works on a different domain. The regular EKG worked on a time domain. This one works on a frequency domain, which opened up opportunities that we didn't know existed, but they do exist. So we're seeing things that I'm going to show you on some slides in just a minute that are absolutely amazing. Now, it doesn't matter who you are with cardiovascular disease now. If you use this device, you can see where you're at with it. You get a number and a score that's easy to interpret, and you can basically take that disease and begin reversing it. I've been talking to the clinicians at HeartFit, and they are one by one picking up the details on how to do this. And so you're in an excellent position to get excellent cardiovascular care. And so I applaud you for everything you're doing. I think Diamond, having met him at several meetings, I sense his spirit in his heart. You're fortunate to have someone like Diamond that is basically fighting on your behalf to give you the dead level best care possible, because truthfully, nowhere in the world could you get better care than through this situation that you're getting now with a heart scan. And you will be the first clinic in the entire country of Canada to have access to it. So you're unique. And
yeah, we're very excited to be bringing this. And when I heard about this the first time, it's funny how it was very serendipitous how we bumped into you the very first time. And yeah, I mean, I think my just my philosophy and the way my energy goes, I'm always trying to find the best ways of helping people prevent and reverse heart disease. And we do a really great job of it here in our clinic. And I think now with the scan and what we're able to learn from what we're able to do from the scan and helping people be able to really reverse the disease process becomes really powerful to help people prevent and reverse heart disease. So I think, yes, it's just my way of looking at it. And I was doing my fellowship stuff down in where was I in the States there. And anyway, I completed that part of it, and I got my fellowship modules done and all that's completed, which is a lot of work, but I managed to go through that. But this is where I bumped into Dr. Sam and his crew there, and Dr. Shen, who's the founder of the clinic. I had it took us a long time to get it here, but it was probably about 9 months in the making, I would say, if I'm not mistaken, something like that. And so it was quite a long time to bring it here, but it's really a game changer for our clinic and allow us to be really accurate. And I'll let Dr. Sam go through that part of it.
Alrighty, well, I'm going to bring out some slides so you can visually see what we're getting into here, and it's exciting. So the MCG, what exactly is this device? And I briefly alluded to it earlier. It's an electrocardiogram that uses artificial intelligence. And this device took over 23 years in development so far. It's been tested on more than 3 million patients. We've been using a cardiovascular database to verify things, and it's helping us see things that, quite honestly, we've never seen before. You see right here where it's talking about going through the frequency domain. That opened up new channels of things that were visible on that electrocardiographic data that was never available before on the time domain aspect. And once you use artificial intelligence, you can see it even better. Artificial intelligence, if you didn't know, it gets smarter with time. So the more studies you do, the smarter it gets. So the sensitivities and the specificity, the preciseness of the test is getting better and better as time has gone by. Now, it's a massive program. It's actually almost double the size of Google. And if you can imagine how big Google is, and the program that went into making this happen is bigger, you say, well, that's incredible because that's a large program. It shows us over 26 things about the heart, most of which that we've never had before. One I'm most excited about is it's helping us pick up disease early. Historically, all of our testing for cardiovascular disease has been reactionary. It will only see things when things got bad. And so always reacting to something when it's bad is a much more complicated process. Quite a few doctors do not know how to reverse plaque like I've been doing for years, and all they can do is slow down the progression. And so if you catch it when it's late, your options become more limited. This is allowing us to see plaque when it just originates. So when you have the very earliest formation of plaque, this device can see it, and that's novel. This device is helping us pick up unstable plaque. You've probably all heard of people that had heart attacks just out of the blue. For 66% of people, heart attacks, the first symptom the person has is the heart attack itself, and that's because a 30 to 50% lesion will have a vulnerable plaque that will rupture, and this machine can pick it up when it's vulnerable. One of the things I'm most excited about.
Pause on that for a second, Dr. Sam, as well, is that many people think that's an opposite way. They wait for we wait for a last cheeseburger and fries, and we end up with a heart attack, and that's where, if you can quickly comment on that, where you're more likely to have more stable of a blockage and less likely to rupture when it's a bigger blockage. So can you comment quickly on that versus the smaller lesion to the
well, so many times people would incidentally catch on a CTA or such a 30 to 50% block, and it would say mild to moderate when it's technically fixing to blow up and rupture next week. Well, the CTA couldn't pick on the fact that the plaque in that 30 to 50% lesion was unstable. Then you might have a 70% lesion that's rather stable because that's how it got to 70%. So it in itself is beginning to cause you some symptoms, but just barely, not stentable at that stage. And so you've got this barrage of 20, 30, 40, 50% lesions that can rupture and cause you to have a heart attack, because you go from 30% to 100% in seconds. The most common time to have a heart attack is between 4 and 8 in the morning. The second most common time is within 2 hours of a high carb intake. And so those were patients with basically unstable plaque doing that. Now I'm excited about this particular aspect of the machine because it gives you a score. Every time you do the test, you'll get a score between 0 and 22. And that's something that you can use as a baseline. And then the next time you have a test, you'll get another score and another score every time you get tested. So if you had a score 1 year and it was a 1.2, and the next year you came back and you had a 2.2, and the next year you came back and you had a 3.2, you would realize each year it's gotten about 1 point worse. And once it gets over 4, it's considered significant. So you're moving in the wrong direction, and whatever your plan of care is, it's not working. And so then you bear down on what the physicians and clinicians are telling you what to do, and you follow instructions, and the next year it goes back down to 2.0, and you say, well, it went from 3.2 to 2.0. That means whatever I'm doing is working. So this machine gives you a simplified number that can tell you yes or no if you're getting better or worse. It's something that everybody over the age of 30 should be having. We're going to start seeing a whole lot more 30, 35-year-old heart attacks now, simply because processed foods and fructose and some things that have changed in the last 30 years across the world. This device picks up small vessel disease. And if you're a female listening to this, you're going to be excited about this, because 49% of women have small vessel disease before they have large vessel disease. That's the little vessels that come off the big vessel. So here's your large vessels right here. And you see the little tiny vessels that come off of the vessels. Those are called small vessels, and they're not seen by nuclear stress testing. They're not seen by a CTA. They're not, which is a CT angiogram. They're not seen by an angiogram that a heart cath that a heart doctor does. So the only way you're going to be able to see this is through this device, because it's able to see what they can't see. And if you know you have small vessel disease, you can measure it from 1 year to the next to see if you're doing better or worse. After 6 to 8 years of small vessel disease, a patient will have extreme fatigue. This can happen in women and men. It's in 49% of women, it's in 15% of men. But at that 6 to 8 year point, when the fatigue gets so severe, you usually end up with a heart cath. The heart doctor does the catheterization. He doesn't see anything in the large vessels. He pats you on the back and tells you, I don't know what it is, but it's not your heart. And then 6 months later, you end up having a heart attack. But the heart attack's not from small vessel disease. You go from 0% blockage of a large artery to 100% blockage of one or more large arteries. So something flips a switch, and then you go from 0% to 100% very quickly, which is one of the reasons women are so hard to pick up with coronary disease, and the 15% of men in this same category are also hard. But this machine is going to change that. This machine helps you see heart failure 6 to 8 years before it becomes clinically evident. So if you knew someone was moving in the direction of heart failure, you could give them clinical therapy that would prevent them from ever becoming a heart failure patient. And that's going to change the way we do cardiovascular medicine in this category. I'm extremely excited about this, mitochondrial dysfunction. If you're over the age of 50, you should be incredibly excited about this too, because it's the first test that's ever been able to pick up on mitochondrial dysfunction, and it's very common over the age of 50. Mitochondria have to do with the energy function within a cell, and they're actually the main controlling aspect of the cell. I used to think that the nucleus was the main controller of the cell, but it's not the nucleus, it's the mitochondria, because once the mitochondria stop producing energy, you become vulnerable. If you have mitochondrial dysfunction in the heart, you'll also have mitochondrial dysfunction in your immune system, your gastrointestinal system, and every other system in your body. When COVID came through and we saw these patients were vulnerable and these patients were not, it was the mitochondrial dysfunction patients that were the most vulnerable. And we finally got a machine on the market that will identify who's vulnerable and who's not. And it's this device right here. This device picks up on rhythm disturbances before they happen. So if you are moving in the direction of atrial fibrillation, you would know it about 3 months before it happens. If you were moving in the direction of ventricular fibrillation, you would know it months before it happens. And then your doctor, the clinician, can do something about it before it actually gets to the dangerous part. And that's the good news. You can avert a crisis. You can sometimes completely avoid the rhythm altogether. This is going to change the way we do pre-op clearances, because it's going to make things that we couldn't see before, like rhythm disturbances, heart issues, mitochondrial dysfunction, and small vessel disease. We're going to be able to see all that now. So when we're doing pre-op clearances, we're going to be able to do a different way of assessing you, and it's going to be safer to put a person to sleep for surgery. It's going to be a whole lot easier to sort out chest pain in the emergency rooms now, because this device will actually tell a doctor within 10 minutes, yes or no, they need to go get a heart cath. Now, I think I was going to stop right there as far as telling you what the machine is. You asked me to limit my time on this area, so that way we'd have more time for questions.
There's a couple of questions already, but obviously there's a lot more coming your way as well. But how was it developing for Scad? So Scad is just for those of you that want to know what Scad is that where you have an artery and the artery kind of rips open, the actual wall of the artery rips open. So how well is it able to detect the possibility of Scad?
Now that's a good question, because we don't have as much data on that particular area, but I would anticipate it would pick up some vulnerability. And what you would see is numbers on the scoring system that would vary. But to answer your question, I'm not 100% positive how that would handle. But as far as plaque instability that you would have as far as plaque in the artery, it picks that up wonderfully well.
So I believe it would start to pick up if obviously that would be a more emergent situation where it's actually limiting flow. And that's where, so if it's limiting flow to the artery wall, then we'd be able to pick it up.
Definitely going to see that.
But if it's early stages Scad, I don't think we'll be able to, because that's not a plaque.
That's the part you're going to have trouble with.
So that might be a challenging. The other testings that we do in our clinic where we look at artery function and stiffness, and they might help on that side of things, or to look at some biochemistry that might be off. That's something that you can consider. But if it was limiting flow, that would be one of them. There's another one, and when we talk about artery disease, we know that artery disease can affect the coronaries, which is the heart. It can also affect the brain. So I guess my question is, how good is it at affecting or looking for disease outside of the heart, so the brain or even peripheral artery disease?
Well, there are 10 diseases that create inflammation. And so this device is actually going to point you in the direction of which diseases might have contributed to that. That's over the head of this conversation, because most of these people watching are not practitioners, but I have been teaching this to the practitioners at your clinic, and they seem to be catching on rather well, extremely well. I teach this almost every night of the week to one or two clinics in the country, and I believe your clinic has picked up on it as quick as any clinic I've dealt with. So, congratulations on some practitioners they seem to be all in.
Yeah, everyone's, we've got a great group of people here for sure. Very passionate and very focused on helping people prevent and reverse heart disease. So for sure. There's just a quick question here as well. I'll answer this one here. Does this view the entire heart or just sample areas?
Oh, no, it views the entire heart. In fact, when you have a blockage, it tells you whether the blockage on the right-sided vessels or the left-sided vessels. And so, or if it's on both sides. And so we can usually predict the area that you're having trouble with some degree of certainty. It's sometimes interesting, because sometimes we'll see a heart cath that shows a blockage in one area, and we're not showing a blockage in the same area. But when we investigate it closer, it turns out the area of blockage that they're seeing on the heart cath or the CTA is actually full of collateral circulation that's working well. And if collateral circulation is working well, it doesn't show up as a blockage, because the area of the heart of concern is actually getting all the oxygen that it needs. And that'll help us prevent putting stents in when they're unnecessary. It'll help us prevent having bypass graft surgery when it's not needed, because those are incredibly big procedures.
Yeah, and I think you had some slides on that part of it, so I'll maybe let you continue that part. But just on that theme of it, when you talk about the trials that have come out now, and it's been a couple decades now, and this is a hard concept for people to understand, but we think of the arteries like a pipe, and they're not pipes, they're muscles. And this is where the trials have come out in the last few years and it's been going on for a couple decades, where doing a heart stent or bypass surgery is not a cure anymore. It's not something that we should ever be doing on patients that have stable coronary artery disease. It's meant for the patients that are emergent, having unstable disease, having a heart attack, that type of thing. And so can you comment on that part of it very quickly? Because I have a good analogy that I'll share with you after you're done that.
Well, for years, people have had unnecessary heart catheterizations because they had equivocal studies on nuclear stress tests and they wasn't positive what we needed to do. So they got the heart cath. But now it hadn't been that long ago where a patient was about to have bypass surgery in Pennsylvania. Our test showed he was doing better than their test said. We had the doctor show us the catheterization, and he didn't do what's called an FFR, which is free fractional reserve, and that tells you if the collateral circulation works. But fortunately, he got good enough pictures. We could see the collaterals, and that person didn't have to have the bypass surgery that was scheduled for the following Monday. That being said, we've never had technology that was so good that would tell us this type thing, so it can help us avoid those big procedures. But you don't want to be doing these unnecessary procedures if you don't have to. Putting a stent in, that commits you to having antiplatelet therapy to a certain point, and you're going to have risk of bleeds in certain areas. There's just certain times where things can go wrong when you put a stent in that risk wasn't necessary. So if you need it, that's one thing. If you don't, it's another. More times than not, you don't need it. Studies have shown medical treatment works just as good, if not better, than places with stents. But I'm sure your medical care, a situation like in my clinic, is almost always better, because all I did for all those years was take care of high risk, usually 95% blocked arteries, and we would basically get them from 95% to 0% over a period of years and get them to safety. But the neat thing is you move them back and you keep the plaque stable, and these patients become asymptomatic and do fine.
So my analogy I wanted to share is just like thinking like a 10-lane highway system, and all 10 lanes are open. And if it gradually closes up, let's say it closes up one lane every month, and that's your route to the office, your body is very unique, and it has a way of always trying to fight, if that makes sense. And so when it gets to half closed and half open, and then you start to, it starts to go to 7 lanes, 8 lanes closed, what are you doing? You're probably not going to wait in that traffic for that long. So you're going to start to find side roads anyways. And so this is why, the majority of people that have heart attacks, actually, it's just less than majority. I think the last study was about 45% of people have silent heart attacks. They don't even know they've had a heart attack. And it's, basically the gradual closure of those lanes. And it happened gradually enough to allow your body to then compensate for that. And that's why a lot of times you'll see people have collaterals that have developed on their own based on, depending on where the blockage is and how it happens. But maybe if you can comment on that quickly there, Dr. Sam.
It takes about 3 years to grow adequate collaterals into an area of poor circulation. So if you can basically slow down the disease for 3 years in an area of a high blockage, you can prevent a person from having a heart attack. And so many doctors that don't know how to reverse plaque, their strategy is just to slow it down and hope to get the patient to 3 years before they get in trouble. And that is one strategy on how you approach this. I prefer the strategy of just reversing the plaque and not dealing with it at all.
Yeah. And I mean, our focus, especially when there is advanced stages of disease, is to, we get a lot of success using external counterpulsation therapy and obviously lifestyle changes to be able to help that. And I know we'll get into that in a moment, but those are the focuses to help give the body an environment to be able to grow new arteries and improve that artery health and function. And so that becomes so important. Maybe I guess I'll start with a quick question there is, what is the conventional strategy that doctors use right now to reverse or to stabilize heart disease?
Well, the typical physician will put a person on a diet of some sort, usually a diet of moderation. Sometimes they wrongly pursue low-fat diets. And then they have a person exercise a few days a week, and then they put them on a statin. They might check a hemoglobin A1C just to make sure they see no obvious signs of prediabetes. But to be honest, it's kind of sad because none of those ways work very well. And so many people go on to have their disease regardless. Now, It's not the cholesterol that's causing people trouble. It's the inflammation that attracts the cholesterol in. And I always teach my patients, it's the one who controls the inflammation wins. Well, you can basically see when you're controlling the inflammation with this test because your numbers get better. You go from a 5.2 to 4.0 to a 3.2. You're getting better each test. I'm not in a safe place. It gives you something to shoot for and to work toward. And we see people improve from 9s and 10s to below 4 all the time now. This mitochondrial dysfunction, it's a huge issue. It's not just a longevity of life, but it's a quality of life. I would suspect probably 40% of the people that are watching this webinar right here have some degree of mitochondrial dysfunction. Once we fix that, your quality of life changes. You start making chemicals in your brain in such a way that you start having the ability to think more clearly. Your memory gets better, your energy goes up, and then a nitric oxide starts getting produced and blood vessels start getting blood supply that hadn't got good blood supply in years, because you'll almost double your blood volume in 2 weeks' time once you start addressing it. There's different ways you approach mitochondrial dysfunction, but about 50% of the patients that have it will go on to have this condition called MTHFR genetic mutation. And it's common. It's in over 50% of the population in both the United States and Canada. And so I think you'll be amazed at what happens once you treat. So mitochondrial dysfunction is not a little thing. It's a huge thing. And the fact that this test can see it, it's a game changer. Things that you used to enjoy doing, you quit enjoy doing. Once you start losing brain chemicals, you'll start enjoying life again because things won't get on your nerves so much. Little things that shouldn't bother you won't bother you anymore, but not until you fix it. Insulin resistance is going to be a big factor in so many of your patients, but now you've got to measure how to address it. Fructose in your diet. Exercise done properly. I recommend to my patients to exercise 50 minutes a day aerobically nonstop, and that's 7 days a week. When you do that, it's like a vacuum cleaner in your blood vessels. These inflammatory factors get in the back wall of your blood vessels, but when you exercise 50 minutes a day aerobically, getting your heart rate up to whatever your 70% level is, you're basically going to remove over 90% of that inflammation on a daily basis. It will come back tomorrow, but you exercise again tomorrow, and then you gain control of inflammation. The one who controls the inflammation wins. So that doctor that was just doing the statin and telling a patient to eat in moderation and exercise a few days a week, that's a losing strategy. If you played football and you lost 10 games out of 10, I would say, well, you're not that good at football. Well, if you're a doctor and you lose 10 patients out of 10, you're probably not too good at medicine either. And that's sad. But once you know where your target is, you've got a chance of winning. I keep saying at the meetings I teach, and I've been teaching nationwide for 25 plus years, if you aim for a target on this side and the real target's on the opposite side, you're never going to hit the real target. And so in cardiovascular disease, you got to aim for inflammation. And that's been a mistake in the area of clinicians all over the world. And we're starting to change that focus gradually, but it's not going fast as I'd like it.
And like when I look at it, especially on the conventional conferences, the cardiac conferences that I go to every year, I'm the president of CACPR, which is our prevention track. And, you're talking to these clinicians and they're all focused on the wrong thing, but they get excited about, oh, well, we got new medication to control this cholesterol or that cholesterol, and it's focusing on the wrong thing. And I think pharmaceuticals are pushing us into looking at the wrong area rather than just trying to fix where the biggest bang for the buck is. And so, I think we're looking in the wrong area.
They're treating symptoms of the disease rather than treating the origins of the disease. Mm-hmm. It's not going to be simply a drug that fixes this. It's going to be a lifestyle. It's going to be a right amount of exercise. It's going to be a careful diet that controls both glucose and fructose intake and looks, very carefully at what you're doing that would affect your liver. When your liver gets fatty and you get more and more insulin resistant, you're setting yourself up for failure. Yeah. In the United States, it turns out 46% of people in the United States, and that's usually children and adults, have fatty liver. That's unbelievable. We're getting up to the point now where 85% of Americans have metabolic dysfunction. But it's not surprising because we started basically subsidizing corn back in the 1980s. Most of the food processors use high fructose corn syrup in the process. Fructose does not measure like glucose, and it doesn't affect things like insulin the way glucose does. And so we're losing some control of how this is metabolized. It turns out fructose is metabolized like alcohol. So we used to see only fatty livers with alcoholism. Now we're seeing 2- and 3-year-old children with fatty livers that never had a drop of alcohol in their life. What changed? Well, what changed was food, and food became processed and it became controlled. And that fructose that you can't actually measure, because when you measure glucose in your system, there's no fructose in it. It basically is playing a factor in what's going on in your liver. Once you lose control of your liver and that insulin starts going up in your body, you're going to start seeing mitochondrial dysfunction and some other issues that you really don't want to deal with. So cardiovascular health is attainable. This machine is going to help you know if you're doing better using your heart scan, getting a yearly test, or sometimes more often than yearly. If you got problems, if your problems are serious, your doctor may tell you he or she wants you to come back in 3 or 6 months. But certainly if you're healthy, you're going to want one of these at least once a year. And that will give you a good clue to know if you have peace of mind because you have a good score or you got a problem because your score is getting worse.
I have I have a few questions here coming up here. So I guess, how does looking at the electrical activity of the heart give us so much more information? I know that answer, but I'd like you to comment on that part.
Well, when Dr. Chin started this 23 plus years ago, when he changed over to that frequency domain, basically when he's talking about frequency domain, he's looking at different parts, 200 plus electrical elements of this data. You're seeing a bunch of bar graphs, and those bar graphs, each of the peaks means something, but it took him years to figure out what this peak meant, what this peak meant, and then finally how you could score them and grade them, and then to get them accurate. And he did that meticulously over about a 15-year period, and then this thing became FDA approved, and we started working at peer-reviewed studies. And so now there's over 12 peer-reviewed studies. There's a whole bunch more in the process. And this thing is hit prime time. The American Heart Association gave this device the Innovation of the Year award back in 2017. So here we are 7 years later, 6 years later, and we're putting it on the market.
And how many people have been scanned so far? I know there's a question there about that too.
Over 3 million.
Yeah. And then in Calgary, in our clinics, we're sitting at about 100 and change. So we're still new. This is still new technology to our clinic, and that's the patients that we've done. I think we've done way more than that in terms of training. So, yeah, we've done quite a few here, and yeah, the staffs are getting great at interpreting the results, and we've got great resources. That's part of it. So, yeah,
I couldn't be prouder of your staff, and when you teach about 2 clinics, at least 1 or 2 clinics a night, you just kind of get used to what to expect. And the staff at HeartFit has exceeded all my expectations. I think they were a little intimidated about the whole device to start with, but they grew to love it, and now they're all over it. And their learning curve has gone so fast, I've been shocked in a positive way.
Yeah. And so I got a few more questions here. So how accurate is the test to nuclear testing or to angiograms? I don't know if you have that slide on there, but yeah. How accurate is it? So just to be to give a little bit of a background to that. So when you go see a cardiologist, let's say we'll take the main path where your family doctor says, you know what, we want to get your heart tested. You're having some chest pain, or you might have a family history. You're going to go see a cardiologist, and the first test that the cardiologist will do, well, it doesn't really count, is an electrocardiogram. An electrocardiogram is kind of a waste of time. It just is a quick 6-second snapshot of the heart. But they do the stress test, and then they'll do a nuclear stress test if they see something of a concern. They call that non-invasive, but it bugs me when they do that, because there's about 1,000 chest x-rays that goes through there and a radioactive dye, and they call that non-invasive, which kind of irritates me. And then, of course, there's the angiogram, which people love to see, how much percentage blockage I have. So maybe those are the 3 tests I give you a little background on that. So go ahead and answer the question there.
Well, basically, the test is a lot more specific. If you notice, the sensitivity and specificity is up in the 91 and 87% level, and that was in 2011. Remember me telling you that artificial intelligence just gets smarter with time. Now the sensitivity is up to about 93%, and specificity is up to about 92%. Here is a nuclear stress test. The specificity is at 14%. There's a lot of false positives and a lot of uncertainty on some of these nuclear stress test evaluations. And so as far as I'm concerned, the difference between the MCG and a nuclear stress test is the difference between college and kindergarten. They're not even close. When we measure the comparison here, we're only measuring one thing. We're measuring how it affects blockage in the arteries. How well does it pick up high-level blockage? But when you think about all the things the MCG does, it picks up heart stiffening, it picks up mitochondrial dysfunction, it picks up small vessel disease, it picks up rhythm disturbance before it happens. These SPECT images, it doesn't even look at those things. So you have zero chance of finding any of that out because that's not even included. When they compare our test to this test, the only thing they're comparing it to is their ability to pick up high-level disease. Well, our machine picks up high-level disease too, but it picks it up better. But then besides picking it up better, it sees all those other things. When you compare the heart scan that I call a multifunctional cardiogram, y'all call it a heart scan, compare it to these other modalities, it doesn't matter which modality you pick. It doesn't matter if you're looking at accuracy, sensitivity, specificity, positive predictive value, negative predictive value. Hands down, the multifunctional cardiogram is better at picking up a high-level blockage. But when you start thinking about all the other things that this machine does, now it's college and kindergarten because these other machines can't even begin to touch that because they don't look toward that. When you compare it to a nuclear stress test, it's comparable. In fact, some ways it's better than when you compare it to a heart cath. It's comparable, but in many ways it's better because you can see small vessel disease with this. You can't see that with the angiogram. You can tell, even if you had a high-level blockage in the left anterior descending artery or the right coronary artery, you would be able to tell if the collateral circulation was making a difference with our device, whereas you can't always do that with, say, a CTA. But if you do that with a heart cath, you have to do a special test in addition to it. Yeah. So hopefully that answered your questions about this device versus the other. And that was all on your recording. So anybody that's watching this that wants to go back and just put it on freeze and look at those numbers, you can study them on your own. Because I know we had to go over that a little fast.
Yeah, there'll be a recording afterwards as well. So like who should do the testing? Like who do you recommend doing the testing on?
Well, since I'm absolutely positive, because we're having 1, 2, and 3-year-old children getting fatty liver disease and insulin resistance and type 2 diabetes, and that's never happened before. We're starting to see 30-year-old heart attacks and heart failures and rhythm disturbances. And so anybody over the age of 30 should be getting this once a year. And if your numbers are good, you can wait a year. If your numbers are bad, your clinician may tell you to get it more often. And it's a test that doesn't have radiation. It doesn't have contrast. And truthfully, it's not that expensive. The cost of this test is very affordable. So I think that it just makes sense to do it as often as necessary to give the clinician and the patient the peace of mind they need.
And I guess that kind of has the same stuff. So why should I do the testing? Like what would be I know you already answered that, Quinn, but it was another question that came up. So
if you haven't got your heart, what do you have? You realize that cardiovascular disease kills more than the next 4 causes of death put together. If you added every cancer in the world put together, heart disease kills more than all of them put together, plus all the next 3 causes of death put together. So this is a huge chunk of what is maiming and hurting and killing people all across the world. So why would you have this? To give you a peace of mind and know you're good, or give you the knowledge you're doing poorly so you can do something about it before you get hurt?
Absolutely. And there's a question that came up there as well, is that why does my doctor dismiss the results of this test? Obviously, it's brand new, and for those of you that have had the test done already, there'll be a form that goes out to explain this to your physicians, but maybe you can go answer that question there.
Anytime there's a new technology that's disruptive, it's going to be looked at with weariness by doctors. By nature, doctors are taught to challenge everything. And it's probably good that we do that as a group, but eventually we look into things and the paradigms shift. If you're the first clinic in Canada to have these devices, then you can be sure that it will be a new finding for your cardiologist. However, I believe when you take that little note that explains what it is to them, artificial intelligence is fixing to enter into every form of life, including medicine. I think just the fact they know it's artificial intelligence tagged in with electrocardiogram, which is something they do know about, they'll start to take note. On that little page that you give them an explanation, it's going to give them the peer-reviewed information. It'll tell them where to go look up the data so they can see for themselves how this works, how accurate it is. Is this for real? And will this help my patients? It will replace some equipment in their office, and they may upset them a little bit. You know, if you spend a lot of money on a machine and you find out it's worthless, a few years later, that hurts your feelings. And when I just told you it's the difference between kindergarten and college, I'm not joking. Their nuclear stress test machine that they spent a lot of money on is now worth about the same amount as a kindergarten education in medicine.
Well, and I've hated that test since it's ever been going. Like the fact that they called it non-invasive, and that really irritates me, because the amount of radiation that goes inside of that test and the radioactive dye. I was with some friends out in BC, and one of the girlfriends, she's around our age, had a nuclear stress test done and felt like crap for 2 weeks. And she's like, I can't believe they made me do that test. It was like the worst experience ever. And they called it hey, it's non-invasive. It's painless. You won't feel anything. And that's the wrong thing to say. Like,
it's really wrong, because you're getting an intravenous injection, and the injection you're getting is nuclear medicine. Now, usually the nuclear medicine leaves you in about 8 hours, but the effects of the nuclear medicine could live on for weeks.
Yeah, no, for sure. Obviously, there are some questions about what to do with the results and how to do that. At the HeartFit clinic, our staff, our physicians, our clinicians will interpret the results. Just to let you know, our process is that we do the test. You'll get an instant result, kind of see where you're at. You'll get a scorecard. If you're doing a different level of assessment, as you know, Dr. Sam, we go into looking at the carotid arteries. We look at the big arteries, the small arteries. We look at the function, the stiffness, because these arteries are muscles. They're not pipes. We do a fitness assessment because, hey, we're a heart health clinic. We want to make sure we can prescribe exercise safely and effectively to you. So we do a very thorough artery health assessment, and you get a report card. And so even if you decide just to do the heart scan on its own, you'll get a report card, you'll get an understanding as to where your risk is. And then every week, our team, our clinicians meet as a group together. Sometimes we mix our clinics together. And so we go through the results as a team, and then we go through the results with you afterwards in terms of a plan of attack. And that's individualized based on the results that happen. And there might be some other things that we might recommend from the testing, but that's kind of our process to understand what we do at the clinic there. And as you all know, is that this is an addition to what we're already doing. We pride ourselves. We've been around for a long time now, for 16 years, and it's been an overnight success. So we decided to open up a clinic, I think 11 years later. But anyway, in Edmonton, and now, of course, in Vancouver, and during COVID there, 2020. So I'm joking about the overnight success, by the way, but it's about finding these tools and making this a great, basically a toolbox, and a very integrative, evidence-based toolbox to help people prevent and reverse heart disease. And so, the questions that you're going to get from physicians, you can direct them to us. You can get the letter from us. We're just in the process of getting that completed. And so you'll get a letter from our clinic to be able to understand what's happening on that part of that type of thing too. So
Let me explain one thing that tags in with that now. Ultimately, with most of these heart scans, you're not going to have to go anywhere, because the person, the clinician who's going to fix heart disease is not a cardiologist. The physician that's going to fix this is going to be a primary care clinician because it's going to have to be someone that takes care of the 10 diseases that create inflammation. Heart doctors are not trained to treat but 2 of the 10 disease states. They're not capable of treating the other 8 of the 10 because they're not trained in it. So if this disease is going to get fixed, it's going to get fixed in the primary care arena. So the only time you'll be sent to a cardiologist tagged in with his heart scan is when you have an immediate need for a potential stent placement, or you have some type of heart failure with valve issues. Most of the time your treatment is going to be medical, and you're going to deal with primarily the clinicians at HeartFit. And interesting enough, they're picking up on great tools to help your disease, and they're already doing great things. You know, the things that they're doing with carotids and other areas to measure inflammation and instability and plaque growth, those were way ahead of their time. And now they're doing this in addition. So your chances of doing well there are great, but your concerns about taking this test to other doctors is going to be fairly rare and infrequent.
Yeah, and this, like I said, you're going to get some healthy ignorance from the physician groups or your GPs or your cardiologists, just because they're not aware of it. And we'll put the letters together and put the research together. But either way, the HeartFit Clinic is going to be there to help you reverse that disease process, and that's what we do really well on that end of it. So why? I guess just some quick questions here on that part of it. But why does it show low risk when I have heart disease? Can you explain that part?
It's like that patient I told you about in Pennsylvania, that sometimes they're thought to have high risk because their heart doctor does a heart cath or he does a CT angiogram and it shows a 70-80% blockage, and then ours shows a minor involvement in the same area. And then when you look closer to the studies that the heart doctor did with these caths or CTAs, you can see collateral circulation. If they do that to FFR, the free fractional flow reserve, they'll basically be able to see it. And they don't need further treatment because these patients actually have the blood supply they need. So it was kind of like a false alarm when they saw the 70-80% blockage, because technically if you've got a 78% blockage but you're getting 100% blood flow there because collaterals are making up the difference, what does it matter?
And that's
the discrepancy. We can see the collaterals and the effect of collaterals where they don't see it as easily.
And that's always important to be able to look at on that end of it. And then why would it, how does it work so accurately? I guess that was another question that came up there as well.
Well, artificial intelligence is pretty incredible. When you start taking these equations and applying them to 200 data points on electrocardiogram, you're just seeing a ton of stuff. And remember that the software platform we're using is almost double the size of Google. Imagine how much intense effort is gone into building that database to look into this patient. And so when you build a database that big and now you've got 3 million patients, it's going to be amazing. But we have just released this to the market. It's just a matter of time where there'll be tens of thousands of these machines across the United States. When you get tens of thousands of these across the United States, that 3 million will go to 50 million in no time. Once this device has 50 million patients scanned, the accuracy is going to be off the charts. It's already better than anything on the market. But
and of course, that kind of segues into, why is this a game changer to the clinic? It's
it's because the things you can see that we couldn't see before. Small vessel disease, early disease, gives you a score that you can measure year to year that's accurate. It lets you see rhythm disturbances. When you had that friend or relative that went to sleep and never woke up, that's because they had some type of rhythm disturbance in most cases. And so when they went into ventricular fibrillation, no one knew they were headed that way. So no one put a defibrillator in. No one treated them medically in such a way to make it reverse. But once you know that and you treat it, these things just go away. Yeah. And so Bill doesn't go to sleep and not wake up.
Can happen. And so there was a question about the 10 disease states there, and I can go through that quickly with you. It's obviously understanding what we do in our clinic. And so we get into understanding what the effect is of sugar on your body, looking at insulin resistance or prediabetes or diabetes. We look at particle sizes with cholesterol and understanding that part of it. High blood pressure, overweight, sleep issues. There you got chronic kidney disease, mental health disorders, autoimmune inflammatory conditions, gut health. That's what we do in our clinic as well, and understanding genetic disorders. And we talked a little bit about that with MTHFR. And so all of this is stuff that we address in our clinic here, and really well. And now we do better. Yeah. There, I did that all by heart there. So thank you for bringing it.
I'm impressed. You didn't need my picture.
So yeah, it's really great information to be able to see that part of it. I think the important part is that what information are you going to get from the test? And there was a question there. We want to move away from the idea of understanding, because I think in our heads, we still think of these arteries like a pipe, and we want to see, okay, well, how much opened is this artery? Is it 20%, 30%, 60%, 70%, 100%, right? And really the idea is it doesn't matter. It doesn't matter if it's a small or large, but the idea is to see what level of ischemia it's showing. Because an artery at 60% is a lot different than an artery that could be at 40%, right? It doesn't matter about blockages. And that's where we have to kind of switch the gears on mindset, because people think we're still in that area and then in that generation where stents came up and they opened up blockages. And now we know that that's not the way to do things anymore, unless you're having a heart attack, unless you're having unstable angina. And so that's a big thing on that. But I really like the idea of looking at these physiopathological conditions as well, and understanding metabolic dysfunction. I think that's super important as well. So
incredibly important. And you can't put a stent in small vessel disease. So for all the patients that have small vessel disease, you still got an ischemia score.
Yeah. So there was a question here. In 2017, you were the American Heart Association. This scan has been around for quite a long time. Who developed that then? It was Dr. Joseph Chen.
Dr. Joseph Chen, and he's a cardiologist that basically retired his medical practice and spent his entire working time developing this device. He's quite the mathematician. You would have to be an amazing mathematician to put the artificial intelligence to work, because there's 7 equations that go into this, and there's 200 data points. And when you put them together, there were a lot of bar graphs and interesting things. But Dr. Chen is, because he's a cardiologist and he has an extreme interest in cardiovascular medicine, he has an amazing amount of understanding of metabolic disease, and thus the mitochondrial dysfunction. That was a huge finding on his behalf, but if he didn't have that knowledge, he wouldn't have known to look for it.
Yeah, we're the first ones introducing it to Canada, by the way. So that's where the introduction comes in from our end. So,
huge.
Yeah. So there was a question there. Steps to reduce inflammation of the heart. I think we went over that. I went over those top ones there. We went over who created this. How much does the test cost? We have a special in our clinic, so it's to take advantage of that. I think there was a question about fatty liver. I saw that there. Fatty liver can typically be assessed in routine abdominal ultrasound. That's correct. Right. So
it can be seen, and also can be detected with an ALT.
Well, blood test. Yeah.
That's a liver function test in the blood.
Yeah.
Just have to know how to interpret the results.
How is the score affected if you've had a bypass or a stent? Does that affect the result?
No. If you've had a bypass or a stent, your ischemia score is going to be better, because the bypass or the stent has improved your circulation in areas that previously had ischemia. So if you had a previous MCG and you had one of those procedures, your number would instantly get better. However, if you did nothing to fix the disease, your ischemia scores would just gradually go back up again until you had another bypass or another stent.
Yeah.
I used to have patients that had multiple stents come see me. One of my patients had 49 stents before I got to see him the first time. Truth be told, if I could have seen him after the first stent, he'd have never had the other 48.
And there was a lot of data early on in this century about overstenting. A lot of doctors just overstenting, and there was unfortunately, a lot of problems with that part of it. And, anytime you saw 60, 70%, it would just go and stent it. And they were doing so much harm to patients that that's where the trials came out. That's where then the Courage trial came out. That came out in, I want to say 2006. Am I right in saying that? 7, in that range there. And then it's been followed for many, many years thereafter with different trials, especially the latest, the ischemia trial, showing that, hey, stents and bypasses are not the way to go anymore, only for emergency. And so this is where the HeartFit Clinic comes into play to help you prevent reverse heart disease. And we're going to have to do another webinar on how we prevent and reverse heart disease. So we'll have to stay tuned for that one. But I really wanted Dr. Sam to be available to answer specific questions that you had. I hope all your questions were answered. I apologize if they weren't. If they weren't, feel free to message us and we'll do our best to answer your questions specifically. But keep in mind that we're a month into this, I think, just a month and a bit into this. And so it's relatively new for us. All our staff are awesome at doing the scan. It's not, the scan itself is not challenging. It's just to make sure how we interpret the results really well. And so we're doing an amazing job with that part of it. But how to prevent and reverse heart disease is an amazing tool. All of you that this is actually, and Dr. Sam doesn't know this, but this is actually being caught by the media, I believe, by next week. There's a press release going out next week about the HeartFit Clinic and the scan. And so you are special on our list here, are taking advantage of the special offer that we're taking for this test. So please take advantage of that. As a client and of the HeartFit Clinic, you're going to take special advantage of that part of it, because this is going to be a really valuable tool to understand where your risk is and to see what's going on there. And it just complements every other tool that we have in our toolbox there. So
I must applaud you. This is great. I think one year, 5 or 10 years from now, we're going to look back and say, when everything's this is coming and everybody's doing it, and say, wow, it started right here.
Yeah, it started at the HeartFit Clinic. There you go. So thank you very much for everyone's time. Thank you very much, Dr. Sam Fillingane, for your time today. Your wealth of knowledge has been an amazing addition to our clinic, and we thank you very much and share so much gratitude to you and your insights. And your knowledge and how you prevent and reverse heart disease is just so complementary to what we're doing at the HeartFit Clinic. So thank you very much. And thank you all for your time today.
Thank you. It's nice to meet everyone. Have a great day.
Thanks, Dr. Sam.